I'll start off this session, and we're going to talk a little bit about asymptomatic carotid disease, and we'll see here if I can make my slide advance. There you go. So, should we be intervening? The answer on asymptomatic carotid, yes, we should. Okay, and now we'll move on now and stay on time. Well, we'll give you a little data. So, historically, we have run trials, randomized prospective trials, looking at endarterectomy compared with medical therapy to determine the efficacy in terms of stroke prevention. And the data has been overwhelming, both for symptomatic and asymptomatic carotid stenosis in every of the numerous, more than 10 randomized prospective trials that have been conducted. It's always demonstrated efficacy and in asymptomatic disease as well. So carotid intervention has been demonstrated to be beneficial, but there have been pretty dramatic advances in medical therapy. And so with guideline-directed optimal medical therapy advancing at the rate that it has, is endarterectomy and our carotid interventions in general still beneficial? Let's just look back at some of the trials. So the ACAS trial was the first trial to look at asymptomatic patients, and it did look at endarterectomy versus best medical therapy. But if you look, the enrollment was a long time ago, decades ago, and it did have a pretty dramatic effect. You can see it reduced ipsilateral stroke, perioperative death or stroke, reduced TIA, perioperative death and stroke, and it was highly statistically significant. But again, this is a very old trial. The medical therapies were pretty limited at that time. It doesn't apply. The ACST trial had a more recent enrollment period, and it enrolled over 3,000 patients. And if we look, patients who had endarterectomy again showed a highly statistically significant benefit. Asymptomatic patients who had intervention had a highly statistically significant benefit overall. It was highly beneficial in men, which was seen in the ACAS trial, but it was also beneficial in women, highly statistically significant. It was effective in younger patients. It was effective in patients between 65 and 75 years of age, which is getting younger and younger as my career progresses. It was very effective, endarterectomy very effective in high-grade stenosis, but also in patients between 70 and 80% stenosis. So the ACST trial really showed continued benefit for intervention as compared to medical therapy, but we have still seen pretty dramatic advances in medical therapies since 2003 when enrollment in that trial stopped. So statin therapy has been widely adopted. It has a pleiotropic effect. I don't need to tell this audience in reducing atherosclerosis, and you can see the mechanisms that are involved, but it's more than just lowering lipid. It has an independent effect on the plaque itself. When we look at the Sparkle trial, it just bears out what was demonstrated in a host of randomized controlled placebo-controlled trials, demonstrating the benefit, in this case, of atorvastatin in terms of stroke reduction. If you look at antiplatelet therapies, those have advanced as well quite dramatically in the last 20 years, and again, we're seeing significant reductions in placebo-controlled trials for antiplatelet therapies as compared to a placebo. ACE inhibitors also have been demonstrated to reduce the incidence of stroke, in this case rapamycin, but this has been shown pretty broadly. And again, statistically significant reductions in stroke as a result of these optimal medical therapies. And then if you look at, so this question is sort of being asked, is intervention still beneficial? And if you look at one study where this was assessed, the annual stroke rate was down to about 3 in 100 in terms of annual stroke risk. So that's pretty low, but when you parse into these data just a little bit, you see that was in patients who had a relatively modest degree of stenosis. The patients being followed overall were between 50 and 99%. But if you looked at patients who had between 70 and 99% stenosis, 3 of those actually had strokes during this observation period. So a 3% stroke rate on the basis of this follow-up is actually quite significant. The other thing that's happened is the ACST trial, we looked at the 5-year results, but now the 10-year results have been published, and actually they've been published for over a decade. But it shows that the patients in the continued follow-up actually have a very high degree of utilization of best medical therapy in the non-interventional arm. So if you take, for example, what is probably the most effective statin use, it really is over 80% of patients being followed in the second 5 years of follow-up, from 5 to 10 years follow-up, were on optimal medical therapy. And you still see a persistence in risk reduction between 5 and 10 years in the surgically treated group. So it suggests that that benefit is continued and persists in patients when they are treated with interventional therapies. The other thing that's interesting to consider is that our interventions themselves have gotten better and safer. And some of this probably owes to additional training and experience in advances in technologies, but some of it, I think, is a result of a reduced risk of the procedure as a result of these still optimal medical therapies that are being instituted in these patients. So if you look at the stroke rates for peri-procedural stroke rates for asymptomatic patients, back in the 1990s, it was 1.6% in these two statewide databases, whereas in 2003 it was down to less than 0.5%. So the surgical interventions themselves have gotten better. We've analyzed the debris that is liberated during angioplasty and stenting that we then capture in a filter and look at both the size of the particles and particularly the number of particles that are generated and captured during angioplasty and stenting, captured in the filter. And if you're not on a statin, it was an average of 42 particles. Patients on statins, it was 16. So that was a very significant reduction and implies that the procedure itself is safer. We've also seen improving rates for stroke and death when plaque stabilization with statins have been utilized in several trials looking at over 2,500 patients cumulatively. So there is an effect of these medications in terms of making the procedures themselves safer. And this really bears out in the CREST trial. Now, the CREST trial was really looking at stenting versus endarterectomy and not really designed to look at the option of best medical therapy. That's going to be CREST 2. But if we look at the component of patients who were asymptomatic in the CREST trial, CREST enrolled both symptomatic and asymptomatic patients. But in the asymptomatic patients, the stroke rate for angioplasty and stenting was under 2.5%. And for endarterectomy, it was 1.5%. So these are the lowest, to this point, these were the lowest stroke rates for intervention that had been reported. And if you look at major strokes, those are under 0.5% for both stenting and surgery. So it's a pretty significant improvement in outcomes for patients being treated with these carotid interventions. Nevertheless, Ross Naylor and others have looked at the stroke rates in the medical arms of trials over the years and really have shown a pretty significant reduction. And the implication is that there are a wide array of patients who are not going to have asymptomatic patients with high-grade stenosis who are not going to have a stroke on medical therapy. So how do we distinguish those patients? And there are a few scoring scales that have been developed. One's the ACS-RS scale for risk stratification. It involves these different components: the degree of stenosis, the grayscale median on ultrasound, plaque area, discrete white areas, and then a history of TIA or CVA. And if you combine and score these variables, you'll see that this is very effective in predicting stroke risk in asymptomatic patients. So it is at least feasible to distinguish patients who are potentially at higher risk. Transcranial Doppler also implies a higher risk in an asymptomatic patient. The more transcranial Doppler hits there are, the higher the risk of a subsequent neurologic event. And that was seen in the ACES trial. And then our group has actually looked at MRI to try to characterize the plaque and see if, in fact, that can be utilized. And we are able to see different characteristics: interplaque hemorrhage and loss of the fibrous cap, in these patients when analyzed with MRI and MRA. And in fact, in patients who had fibrous cap rupture, were actually at risk for developing a subsequent stroke in the follow-up period within 15 days of the initial study. So there are opportunities to identify the highest risk patients. I don't think any of these can be broadly applied currently. I think it's too complex as a screening tool, but it does give us some insight into potential selection of these asymptomatic patients. So I would just conclude and say that the level 1 evidence still supports carotid intervention for the prevention of stroke in asymptomatic patients. And ultimately, we'll see the CREST-2 trial has now completed enrollment. There are 2 arms in this trial looking at either medical therapy versus carotid stenting or medical therapy versus endarterectomy. And we should have at least some preliminary results from that trial shortly, perhaps later this fall, and we'll have to analyze those and make a further determination. So with that, I'll thank you.